to our third abstract. Dr. Carlos Fernandez de Larrea from Barcelona is going to present an abstract entitled The Efficacy of ARI0002H, Bcma-Directed CAR T-cell therapy with fractionated initial therapy and booster dose in patients with relapsed and refractory multiple myeloma. Carlos, thank you very much for submitting it to EHA.
Good morning. Thank you so much, Professor Almeida. It's a real honor to be presenting this result, and we are going to comment this afternoon in the Presidential Symposium about our results on efficacy and safety of ARI0002H, that is an academic Bcma-directed CAR T-cells for patients with refractory relapsed myeloma. I'm Carlos Fernandez de Larrea from Hospital Clínic in Barcelona. I am here on behalf of all the Spanish researchers in this project. Here you can see my conflicts of interest. We have developed our own CAR T against BCMA, the most targeted antigen in this disease for immunotherapy, that is called ARI0002H. It's a CAR T that has been humanized and directed against BCMA with a 4-1BB as co-stimulatory molecule. After our results in vivo and in vitro, we decided to explore in a clinical trials with the primary aims to explore the safety with the rate of immunological in terms of cytokine release syndrome and neurological complications, as well as efficacy in terms of overall response in this population of patients with refractory myeloma. Thus, we know that they don't have, even the prognosis has improved significantly in the last year, they don't have a clear standard of care and they have a poor survival. We conducted this research in 5 centers in Spain. We coordinated and produced the viral vector in Barcelona. CAR T-cells were produced in 2 facilities, in Pamplona and in Barcelona. And together, all the 5 centers recruited the patients, performed the apheresis, and treated locally their patient. That was one of our main objectives, to treat the patient the closer possible to their homes. The patients were with a median 4 previous line of treatment. They were all younger than 75 years old. And one of the particular ideas, after we have learned in our previous CAR T for CD19 malignancy, this is approved for exceptional use in Spain, ARI01, it was to fractionate the first dose of 3 million of CAR T cell in three bags, and a second dose that is the completely new, a second dose of other 3 million of CAR T cells after at least 4 months of the first infusion in patients with some degree of response and non-limiting toxicity. The main result is here. All the patients showed some degree of response. That means at least partial response. 63% of the patients achieved a complete remission, and 93% a very good partial response or better. That was associated with a 96 and 92% of negative minimal residual disease in bone marrow by next generation flow at days 28 and 100. We see in terms of extramedullary disease, we see that also all but 1 patient with plasmacytoma responded to this therapy. We have a median follow-up on 1.5 years. And at that time, 53% of the patients are alive and without progression, and almost 3/4 of the patients are alive after these 18 months. In terms of safety, we see mild CRS, mild immune effects in 90% of the cases, but we didn't see any grade 3 or grade 4 CRS, and we don't have any case of neurotoxicity, acute or late. In conclusion, ARI02H production is fast and feasible. It's 11 days of our time of production. Patient achieve deep and sustained response with low-grade toxicity. We are also to mention in the afternoon the potential impact of the second dose. We think that this academic humanized CAR-T against BCMA will be a promising therapy for patients with relapsed refractory myeloma. With this kind of academic, I always want to recognize the work of these 5 centers that are participating in Spain and our patients and their families, and to all the team in my institution that consider as a priority the development of these strategies for the treatment of our patients. Thank you. I'm glad to take questions.
Thank you very much. Very exciting development. Please.
Hi, Nancy Melville with Medscape Medical News. Is there an existing FDA-approved CAR T-cell therapy for multiple myeloma? And how would this add to or improve upon that?
Yes, we have already 2 drugs, not 2 CAR T-cell approved in Europe, ide-cel and cilta-cel. And they have impressive results in heavily treated patients. But we know that we don't have any, at least, for example, in Spain, we don't have any option now for treating patients with either ide-cel or cilta-cel because we don't have reimbursement or possibility of production. And that is the reality in the majority of patients in Europe. I think that as many options that we can have with efficacy and safety as we have with the results, I think that it's going to be an improvement in the survival and also, I think, in the quality of life of our patients. I think that this efficacy is, I think that is comparable at least to one of the no inferior or even superior to one of the results with the commercial ones, and we have a safety profile that I think is very convenient for our patients.
Thanks.
Any other questions? Can I just again ask for a comment? Because this is really very exciting in such a difficult disease where we know that these relapsed and refractory patients have a very, very poor prognosis. To have such an impressive response rate that is quite durable in many patients from what you've shown. How do you see this moving forward in terms of both clearly being academically produced, the availability is different and perhaps easier, but also in terms of moving up lines of therapy. Do you see this being used earlier in the stage of the disease to produce longer remissions at an earlier stage, giving its efficacy?
Yes, we are now recruiting a second cohort of 30 patients, and we are very lucky that we have more than 17 patients already fused in the second cohort. You know that in Spain we are very fast in terms of recruiting patients in clinical trials, at least in myeloma, and because of our previous network. And I think that the idea was to confirm the result and to try to gain some kind of approval for the treatment of our patients. To move to another indication will be fantastic. For example, other patients that they don't have options, so many options for the treatment, even in early lines and relapses. For example, patients with AL amyloidosis, or we have treated 1 patient outside the clinical trial, or even primary plasma cell leukemia. There's also a disease with a very poor survival now. And I think that we are, for example, in our trial, we consider after 2 previous lines of treatment. The approval in US is after, for example, is after 4 lines of treatment. We think that when the patient are refractory to lenalidomide and daratumumab as our patients, the options with a real impact in the survival of patients are not so convenient right now.
Thank you. And just one more brief question. Your study was centered in Spain, and you do have a very efficient and very collaborative network, which I'm sure is the envy of many countries, especially mine. Could I just ask, how do you see the possibility of this moving beyond Spain? So, this production that you have in Barcelona, can this move beyond and be exported, so to say, and be expanded for access to other countries, which would be other patients, of course, which would be very interesting.
Yes, probably that will be a fantastic mid-term goal, and we have received some proposal, and we're evaluating all the, all the technical, logistic aspects, but that will be fantastic to offer this treatment to patients across Europe.
Great. Thank you very much, Carlos.
Thank you.
Thank you for presenting this at EHA.